Welcome to Macro Hive Conversations with Bilal Hafiz. We aim to bring you the best in macro and markets thinking. To see our latest thoughts and analysis on the world, visit macrohive.com. I'm very excited to have our first scientist as a guest on this episode. But before we go on to my conversation with him, I wanted to flag some of the work we produced this week. We give our optimistic take on the EU Summit and Recovery Fund, we featured a big picture piece on the dollar's dominance in the financial system, and we gave our take on the Chinese renminbi and other Asian currencies. We've also launched our China growth tracker. It's well worth following. All of this you can find on macrohive.com. And as usual, we've also had great discussions on our Slack channel with members. Make sure to subscribe to become a member to access all of this. It's the weekly cost of a few cappuccinos. And I also wanted to flag that we offer special corporate rates too, so you can subscribe through your company. Just ask your company to access those rates. On to this week's podcast. I have a conversation with Professor Justin Stebbing. Justin is a professor in the Faculty of Medicine at Imperial College London. He initially trained at Oxford before having a residency at the Johns Hopkins Hospital in the US. He then returned to the UK to work at the Royal Marsden, Barts, and now Imperial. He specializes in cancers and immunotherapies. He has an extensive research background, having published over 550 peer-reviewed papers. He recently published in the Lancet new research on using AI to find drugs to treat COVID-19. From all my sources, he was one of the first to spot the seriousness of COVID, and he's been producing daily updates on COVID ever since. For me, those dailies are perhaps the best regular analysis and commentaries that I get on COVID. So on to our conversation. Welcome, Justin, to our podcast. Thanks very much for joining us.
My pleasure. Thank you for having me.
Probably the first question I wanted to ask was, I know your background or your specialty is in oncology, cancer, yet you write perhaps some of the best commentary and analysis I've seen on COVID. How do you square the two? As an outsider, I would think to write really well and understand COVID really well, you need to be some kind of virus person, but you seem to be able to bring together so many different areas.
I think of healthcare as a global challenge, and obviously the COVID crisis has hijacked healthcare systems all over the world and numerous people. I'm very personally interested in it. Like many people, it's affected my family a lot personally. And I was very lucky that at the beginning of February, a group I was involved with at Benevolent AI and myself were searching for a drug that might be useful. And we came across baricitinib, which is a drug that inhibits inflammation. But what was surprising was that it looked like it was an antiviral as well. And at the beginning of March 2020, Lombardy in northern Italy was the global epicenter of the pandemic. And numerous hospitals and doctors were contacting me and asking me about baricitinib, which can be taken in this case for a short time. And cutting through all of this, what's very apparent when you have patients one's looking after with COVID pneumonia is that the drugs probably don't make an enormous difference. So we're relying really on a vaccine. And on Monday, we had the data releases from CanSino, a Chinese company, in about 500 patients, from AstraZeneca, the Jenner Institute, and Vaccitech in over 1,000 patients, and another one of Pfizer-BioNTech's 4 products, all showing varying degrees of stimulation of both the cellular T cell and the humoral B cell immunoglobulin immune response. But importantly, the strength of the antibody response, which antibodies traditionally relied on, seems enormous. Now, the caveat to that has been people saying, well, in asymptomatic and mildly infected individuals, we're seeing the antibodies disappear. But the reality is we don't walk around every day with elevated levels of neutralizing antibodies and other antibodies to every pathogen we've seen as a child and an adult. Those antibodies go over time. We remember that we have made them.
So what we're saying there is that even if the antibody fades, which, as you say, our blood or body wouldn't be able to handle having that level of antibodies for every pathogen around, when we get exposed to the virus again, would the body fire up again and the antibodies would arise?
Absolutely. Now, what the neutralizing antibody titers can tell us is the strength of the initial immune response to the virus. So what we now have is 2 phase 3 trials with mRNA-based products. Those are products that you can manufacture and scale up very rapidly. It's likely that vaccine will be given an emergency use authorization, which has raised my confidence enormously that we'll have a vaccine before too long. Now, we don't know how long the vaccine will last, but we know that individuals don't get reinfected. I've not seen a convincing case of reinfection ever. I've seen some magazine type reports, but I've never seen a report in a good journal. And we dose the flu vaccines every year. So I'm very positive about vaccines.
On the reinfection, is it the case that the severity of the infection matters or not? Could it have been someone had a mild COVID infection, which we didn't pick up, and then you get reinfected with more severe form? Could that be the case?
Well, if you look at the seroprevalence studies, which includes and detects people who never knew they had infections or had very mild infections, we're also not seeing reinfection in those individuals as well. So what's going on? It could be the T cell response. It could be very low levels of persistent neutralizing antibodies. Or maybe they'll be reinfected in months to come. The virus at the end of the day is only 6 months old, so we're learning about it every single day. Its ability to cause suffering, though, and huge suffering, is really quite profound. I've seen things and the way it's affected individuals and the autopsy series showing clots and pathology, not just in the lungs, but in the kidneys, the liver, the heart, to the brain, and every organ. My uncle was ventilated for a month before he died in York Hospital. He was headmaster of the largest school in Yorkshire, so no guesses how he got it. But the types of pathology we're seeing are very new to us. But on the other side, if you think about it, say with HIV, which was discovered in 1983, that's now a disease that with the right treatment, you live with it, you don't die from it. But there's no vaccine against HIV. It's a very mutable virus. Whereas in this case, I suspect that before the end of the year, we'll see the New York Times or London Times headline, vaccine for COVID. Of course, that will only be available at first for elderly, healthcare workers, and so on. But making mRNA in a bioreactor, I was talking to Stefan Bancel, the CEO of Moderna, about it. For one dose, it's going to cost him 15 cents to make it, if that. The capacity to produce it is enormous. Of course, there are logistical problems. That's going to need -80 cold storage. But these logistical problems, the fact that some people, African Americans, Republicans, are anti-vaccination, for example, these are all problems that are overcomable with science leading the way out of the pandemic.
Just a few questions. I mean, there's a lot in what you've been saying. The first question was just around the B cells versus T cells, or antibodies and T cells. There's been a lot of writings about antibody responses, and I've noticed you've started to talk a lot more about T cells, and I've noticed T cells being mentioned more. I mean, what's the significance of T cells versus B cells here?
I'll start, if you don't mind, with a bit of basic immunology. So our immune system is made of the innate immune system, like our skin, saliva, tears, cells like macrophages, which gobble up foreign proteins. That has no memory. And then you have the adaptive immune system that has a memory. Now, the adaptive immune system is basically the T and the B cells. And that matures with age, with time, the T cells in the thymus, the B cells in the spleen. Now, the B cells make antibodies. Antibodies are immunoglobulin. Now, T cells are a bit more complicated, and they're divided into CD4 T cells, which actually help the B cells make antibodies, and cytotoxic T cells, CD8 positive T cells, whose function is to differentiate self versus non-self. And if it's non-self, like a virally infected cell, which have certain flags on them, they can kill it. Now, every vaccine thus far made, from smallpox to polio, MMR to DTP, relies on a neutralizing antibody response. We know that Oxford's vaccine, CanSino's vaccine, and interestingly, Pfizer and BioNTech's vaccine, and Moderna's vaccine only for CD4 cells, not CD8 cells, stimulate varying levels of the humoral B cell and the cellular immune response. But my conclusion of that thus far is we don't know, there's no clear winner. But what we do know is the phase 3 trials have clinically driven endpoints. So we're going to get an answer.
And when you talk about phases, how many phases are there in these trials?
So what we've seen so far is this sort of mishmash of phase 1 and 2, where we've looked at immediate safety and tolerability. How bad are the fevers, myalgias, headaches people get? Do you get them after the first dose or the second dose? Because all these vaccines need a booster. And we've looked at their ability to stimulate T cells and their ability to stimulate a humoral B cell antibody response. The bottom line is, we don't need to talk about it because the trials are starting, and the question is, do they prevent symptomatic COVID infection? The FDA's guidance on this is actually remarkably simple. It avoids all the complexities about levels and durability of the antibody response. It's basically saying, does it stop people getting sick from the infection? And then as a secondary endpoint, does it stop infections, for example? And so we're going to get the answer. And because these trials have interim analyses, we're going to have the answers, because in America at the moment, new cases correlate with mobility as measured by Google Maps. Now, I'm not saying that Google Maps measures mobility, although it's a reasonable surrogate of mobility, and there's outliers to that, like in LA, where you have these close-knit Hispanic families, which are intergenerational, living very close together. Doesn't quite correlate with that, but for the most part, mobility correlates with cases. So we're going to get the answers, because yesterday in America, the 7-day moving average is steady at about 60,000 new cases per day, 50% occurring in Florida, Arizona, California, and Texas.
And in terms of the speed of all of these trials, I remember when COVID first started, people were talking that typically it takes 5 years or 10 years to get vaccines. Now we're talking that we could get something before the end of this year. These timeframes, how can we compress it so quickly?
So 3 reasons. Number one, previous vaccine companies, because of the long life cycle, the expense required, have been underfunded. Now that's not the case. You can see that yesterday or the day before, on the back of positive data, BioNTech raised hundreds of millions more. For example, BARDA are funding some. You've got big drug companies involved at the forefront. That's number one. Number two, what I've seen is the speed of collaboration between academia, biotechnology, pharmaceutical companies, regulators, and governments is unprecedented. And then the third thing is the science. We've never had an mRNA vaccine before, but it looks like we're going to have an mRNA vaccine as a new frontier. That's obviously got a much shorter manufacturing time. You can change it to keep up with any mutations we may or may not see in the virus. And the science and the scientific advances are remarkable in itself. So all those 3 things together, collaboration, funding, and scientific eye together, has been absolutely tremendous.
And so your sense in terms of timing of a workable vaccine, you're thinking we could see something before the end of this year?
I think, based on US cases, we will have an interim readout before this year, before the US election on November the 3rd. I think that it will work based on my knowledge of neutralizing antibodies. The level of the neutralizing antibodies we've seen in the Moderna New England Journal of Medicine paper, 3 times that we see in convalescent plasma typically. That's the blood of people who've recovered from symptomatic infection. Because what a vaccine does, after all, is it's meant to not give you the infection, but mimic the natural immune response to the infection. So the combination of those 2 things means I think it will work, but it's possible they all fail. And that the second wave of vaccines, Johnson & Johnson, Sanofi Glaxo, with the Clover, the CureVacs, the Inovios of the world, will be able to learn from the first wave if they fail. But I think the vaccines will work. What we won't have is long-term safety data. But one would probably say if there is a bad event, say, occurring 1 in 10,000 times, that's probably worth it. We know there are no short-term safety issues. Yeah, you get fevers, injection site reactions, a bit of pain, redness. Sleeplessness was mentioned in the first Pfizer reprint. Those are all livable with. What we don't want is something like an antibody-dependent enhancement where the vaccine actually makes the infection worse.
Yeah. And earlier you talked about the mutability of the virus, and it seems like there haven't been that many mutations. Is that the case? And what's your take on that? Why isn't it mutating more rapidly?
Well, it doesn't have an enzyme like HIV does called a reverse transcriptase that deliberately introduces mutations into it. The virus is a true RNA virus in that the RNA is episomal in the cytoplasm. It doesn't go into the nucleus. And the first protein it sort of makes in its life cycle is a helicase to replicate that and make a few structural proteins. Now, it doesn't have an error-prone mechanism. There are, I've read about 20 mutations in the virus, but in a virus of this size, that's not many at all. Now, we know in the spike protein that there is a mutation that is now very prevalent called D614G. That means at the 614 position, one amino acid is changed to another.
And the spike protein is the important thing we have to identify. Is that right? Is that the protein we have to try to target?
Well, I don't know whether we have to try to target it or whether it's the best target. But the reality is that because it's on the outside of the virus, every vaccine is targeting it. Now, Some people think that, and there's a Cell paper, that it actually is a more infectious variant of the virus. Now, when the Chinese first published the sequence of the virus in early January, which is what the mRNA sequence is based on, that mutation wasn't prevalent and that wasn't in there. So whether that then influences both vaccine design, the ability of vaccines to respond to the virus, remains to be seen.
Okay, yeah. The punchline, so to speak, is that it's a relatively stable virus.
It's a very stable virus.
Yeah, okay, which is, in the end, good news from a vaccine perspective.
Absolutely.
I just wanted to talk a bit about some of the practical sides of COVID. I know you treat lots of patients, but in your experience or research, what are the clusters of symptoms that's typically associated with COVID?
Typically, after infection, there's an incubation period of, say, 5-6 days where there's no symptoms, and that's called pre-symptomatic. If people go on to have no symptoms, it's called asymptomatic. And then typically it causes mild symptoms like a mild flu-like illness, where you may have no fever, but you may have headache, loss of smell, muscle pains, cough, sore throat, chest pains. You may also have gastrointestinal symptoms such as diarrhea, loss of appetite. Neurologic symptoms, I mentioned loss of smell, headaches. But then after a little time, people can start to develop a pneumonia. Now, that's typically bilateral, quite fluid, and that goes one of two ways. It either worsens and people end up being ventilated or worse, or people recover with supportive therapy. We know that things like lying people on their front can work. Oxygen and trying to avoid ventilation can help. Various drugs can help a little bit. So we're learning really how to manage people better. It's really a lot of small things making things better. Obviously, that's come at huge cost of regular care. You mentioned right at the beginning, I'm an oncologist, and we had to stop cancer treatment or switch to tablet treatment in huge numbers of patients. And, the cost to those patients, and obviously delays of diagnosis, decrease of diagnosis of cancers have been huge. However, there are a lot of intriguing things going on that are hard to explain. There's been a steep decline in the number of premature births, for example, things that you can't normally explain. Now, you can understand why that heart attacks and strokes have decreased, because people have been scared to go to hospitals that are regarded as epicenters and so on and so forth. But you can't explain, for example, the papers that I'm now seeing from Ireland and Canada on the decreased numbers of premature birth. These things are really important to understand the interplay. Obviously, the harms and the effects of COVID extend all the way through the mental spectrum, whether it's unemployment causing increased suicides, domestic violence, alcoholism, fetal alcohol syndrome. But we're starting to learn about the psychosocial effects, the effects on depression, self-harming, more and more. But there's some things that, even as a hardened scientist, I find very difficult to explain.
And then, some of the other peculiarities are things like, why does COVID affect people from different ethnic backgrounds? Black and Asian, well, at least in the UK. I'm not sure if this is a global phenomenon or not.
Well, it's certainly a global phenomenon. In America, the death rate amongst Black Americans and Hispanics, Latinos, is far higher than in white Americans. If you look at the map of New York and you look at where the deaths are, it's in the poor, deprived African American, Hispanic boroughs. Now, there are a number of reasons for it. Number one is comorbidities, obesity, diabetes, cardiovascular disease existing to higher levels. Number two, overcrowding, leading to increased infection control. Number three, there may be biologic susceptibilities. For example, lower vitamin D levels may make people more susceptible. Maybe there's a genetic predisposition that we're going to identify when we do our larger genome-wide studies. And number four, this also seems to be a disease of poverty and deprivation, not just a disease that is indiscriminate. And we've seen this before with other pandemics. We've seen this in the Middle Ages with the Black Death and the plague. This isn't a new phenomenon. This isn't a surprising phenomenon. When people have dug up skeletons in Leicester that died, in the Middle Ages of rampaging diseases, the Black Death and the plague, it was the poorer people who were the most susceptible, who died first. In Italy, people with various infections at times of border disputes were given the infections, or when they got the infections, were told to go to enemy areas. These stories are well described. And, there's some things that will always be true. Pandemics create social instability. They create financial instability. And of course, they create health instability.
And I was going to ask, in terms of the age distribution, obviously the elderly are heavily affected by this. Is it a surprise to you in terms of the incidence of COVID? Like young children, why don't they get it as much? Is it just a case of younger people are healthier?
What you're asking is a really important question because it has implications for vaccine approaches. The studies I just talked about that we've seen, though, neutralizing antibody responses to, and the cellular immune responses to, the B and the T cell responses to, respectively, typically recruited Caucasian people aged 18 to 55. But this is a virus that is an elderly killer. Let me be clear about that. About half of the 40,000 or so deaths in the UK have been in nursing homes. We don't really understand why it has a tropism for obese people, for elderly people. We understand some things. So levels of the ACE2 receptor, the angiotensin converting enzyme number 2 receptor, are low in children and higher with age. We know things like that. We know that you get immunosenescence with age, a sleepier immune system. We know that you get an inflamed immune system with age, but we have so many unknowns as well.
And in terms of elderly, is there a certain age threshold, or is it more of a fuzzy boundary? Is it 70 plus? Is it 65 plus?
Yeah, the boundary to me in the studies is very clearly at the age of 65. And it really scares me in elderly people with its ability to cause such a diverse range of pathology. There was a paper out of Spain last week in the journal Neurology showing that in 850 people, half of them had long-term neurologic complications. Now, a neurologic complication may just be loss of taste and smell, but we really don't know the long-term consequences of the virus. And now, if you look at America, where you've got a steady run rate of, say, 800 deaths a day at the moment, less than previously, but still staggering, I suspect that the level of walking wounded is about 5 times that. It's a very humbling virus. To me, the stupidest virus is cleverer than the cleverest immunologist, in the way the stupidest cancer cell is cleverer than the cleverest oncologist. This was a true black swan event. But why was it such a black swan event? We had SARS and MERS in 2003, then a decade later, we've had Zika, HIV, foot and mouth disease, various bird flus and swine flu. What's going to be the next pandemic?
Yeah. Actually, speaking about the previous ones, we also had the Hong Kong flu, Asia flu, in the 50s and 60s. The reason I mentioned those were the governmental response to that wasn't as dramatic as what we're seeing today in terms of global lockdowns and so on.
Well, that's because it didn't kill people like this virus. It doesn't cause the suffering, and it doesn't seem as contagious, and there's a vaccine for it.
And what's your view then in terms of today's governmental response? Everyone talks about the Sweden approach of herd immunity versus, say, the full lockdown approach of many of the other European countries. What's your take on that? That seems to be something that keeps coming up all the time.
I'm in two minds about it. I think that every country has its own problems and its own unique infrastructure. In Sweden, they have a lot more space. It's not like New York, Paris, Madrid. 40% of people work from home anyway. Quite a fit population with a low level of comorbidities, but probably exposure as children to a lot of other coronaviruses. And I'm in two minds about it. I've heard arguments on both sides. I do think the excess mortality, though, was too high. But at the same time, people can practice non-pharmaceutical interventions, social distancing, masks, without a formal economic lockdown. And there it comes to common sense. And in my experience, if you look at the behavior of Swedish people, people were diligent. The question you may ask in America at the moment is, to avoid lockdowns, are they prepared to take the continuing excess mortality, and for how long? And at what level will they take it? And do we have the Beijing-like contact tracing armies, which clearly we don't, that we can perform a focused regional lockdown if necessary on a targeted basis based on rapid turnaround of tests, rapid tests and contact tracing? Can we get on top of that? Well, clearly not in the Western world. So you have to marry all these things on a country-by-country basis. In Beijing at the moment, they can do 1 million tests a day. And when they had an outbreak recently, at that huge market, which is the size of the British town, they immediately locked down 12 districts of Beijing, knowing exactly where, mobilized an army of like 100,000 contact tracers. Now, although in bits of Rhode Island and Massachusetts, they may have physical contact tracing. In the Western world, the reality is very few people are downloading apps. Even if they are downloading them, they're not keeping them open. That was the case in Singapore. It wasn't in Taiwan. And if you look at the difference between Singapore and Taiwan, it was a much more severe virus than Taiwan, which wins my gold medal award for behavior.
And why do you think the whole sort of technology route of apps hasn't worked? Is it just habit? Was the technology good?
I wouldn't say it hasn't worked. It still relies on people having tests. It still relies on people willing to share information. And I think people are concerned about civil liberties and data privacy. And it still relies on people manually inputting information. So on that basis, I think we've still got a way to go. And there was a recent Lancet public health paper that the contact tracing off the back of apps needs to be very, very quick. And you still need people for that.
Yeah. I mean, speaking of America, I mean, obviously they've had a very high infection rate at the moment. The number of cases has gone up quite a lot, this extension of the first wave. But, the number of deaths hasn't gone up dramatically. Is that just a question of, it's a lagging indicator?
Three things. It is a lagging indicator and probably lags longer than we think. Number two, it is going up, but not like it did previously. The death rate's about half of what it was in April. But then the third point is, number one, the virus has already killed a lot of susceptible and or vulnerable people. Now, for the virus, susceptible and vulnerable probably means the same thing. I'm susceptible because I'm a healthcare worker. I'm not vulnerable because I'm fit and young. An old person is vulnerable, but if they're alone, they're not susceptible. But for the virus, susceptible and vulnerable are probably the same, number one. Number two, we're treating people from nursing homes now. In America, they've had a terrible nursing home problem, as we have had in the UK, as they have had in Belgium, where they counted every death as a COVID death. We're now exporting people from nursing homes into hospitals. Capacity is better in hospitals because we've still got that surge capacity. And of course, our treatments are better. So when you put all of that together, the death rate is much better.
And in terms of a proper second wave, say, let's say in Europe, where you have seen, a clear decline in the first wave, how are you thinking about second wave? People are talking about, okay, after the summer, when we enter autumn or winter, the flu season arrives, then we could get a second wave. People by then presumably are less diligent as well. So that's kind of the general expectation.
So to me, in Asia and Europe, the virus has been controlled. So if there are substantial new cases, that's the second wave. In America, it's a continuation of a first wave. But forget about what you call it. The worry I have is that a vaccine doesn't work, although the paradox is that because of US mobility, we'll probably be able to have a readout sooner. So the big fear of mild COVID plus mild influenza equals a dead person with a successful vaccine trial probably won't happen. So that's my bit. Coupled with the manufacturing capabilities of these mRNA companies and adenoviral companies and the real pharmaceutical and governmental and funding muscle behind it now.
Yeah. So kind of strangely, the fact that the US still has a high number of cases kind of helps in the whole vaccine discovery process.
Well, it does, for sure, because these are event-driven studies. Now, if no events happen, we can't say the vaccine's working. I think it would be very unusual for a regulator to approve a vaccine based on a neutralizing antibody response. Now, it's possible that in 6 months' time, we realize that a neutralizing antibody response exactly correlates with clinical protection. And we know which bit of the protein you need the neutralizing antibody response to. Do you need it to a bit of the spike protein, the whole spike protein, or the RBD, the receptor binding domain? What about the effect of the D614 gene mutation and so forth? It's possible. So it's possible the second wave of vaccines won't need these big clinical studies. We don't know, and we certainly don't know about the durability of the vaccines.
And if you were an advisor, say, to the UK government and then an advisor to the US government, what advice would you give, say, to the UK government?
I would say to the UK government that masks and non-pharmaceutical interventions look really, really useful, and that the younger population can and should get back to work. And that If people are going to nursing homes, people need twice weekly testing, and we need point of care testing with rapid turnaround of results. That includes healthcare workers like myself.
And in terms of school policy, because many of us have kids and this has been a big issue, come September or whenever schools start, how would you kind of manage the school process so that we kind of minimize the COVID spread? So presumably the kids themselves are a low probability of being a node of infection, but it's probably the parents and the teachers, I guess.
So a number of comments to make. Number one, kids don't get sick from the virus. They may do, but the number of people under 20 who've died of the virus in America is, I think, 10, and in the UK it's 5 or something like that. The numbers are very small. Number two, there is this scary multi-system inflammatory syndrome you may have heard about in children, a Kawasaki-like disease characterized by really sick kids and coronary artery aneurysms. That is both rare and, if you look at the incidence of it, may affect 1 in 100,000 children. Now, to make a school policy based on that scary headline is the wrong thing to do, because the psychosocial consequences, not just to children and delaying their education and their friendship, but to parents as well, of not being able to work and school teaching and kids driving you mad at home, are vast in my view. And I think kids should go back to school. Now, whether you want some form of social distancing, which is hard in schools due to limited space, or staggered classroom sizes or smaller classrooms and so forth, I'll leave that up to people smarter than me or more knowledgeable than me to decide. But various models have been tried. The transmission of the virus, it's an indoors transmitted virus transmitted by someone talking to you face to face. Probability of transmission is the number of viral particles you're exposed to multiplied by time. Someone's sneezing at you, that's bad. Now, in a casino, people sit next to one another, so there's few super spreader events from casinos. The air conditioning units suck air upwards. In meat packing factories in southern Germany, in poultry factories in Yorkshire, people work very close together. The air conditioning units are on, circulating air in a very directional fashion. And we know the virus likes 4 degrees centigrade. So when you put all of that together, we know that there are some environments that are more important than the people. There are no super spreader events of aeroplanes, to the best of my knowledge. The recent Emirates flight to Hong Kong, where 26 people came off infected, well, they're almost certainly infected before they got on, and we don't know what happened to subsequent infections since. So to me, the environment is more important than the index case.
Well, I think we've covered a huge amount of ground here.
I think we've dealt with everything from transmission to epidemiology, testing to treatments, and of course, vaccines.
Now, I imagine lots of people will want to follow you in some way. What's the best way for people to kind of connect with you or reach you?
They can email me at my Imperial email address, just j.stebbing@imperial.ac.uk.
Thanks for listening to this episode. Please subscribe to the podcast show on Apple, Spotify, or wherever you listen to podcasts. Leave a rating and let other people know about the show. Also, sign up to become a subscriber to our research at macrohive.com. We'll be back soon, so tune in then.